There's a lot of clinical questions as to whether people who reside in neighborhoods that are lower in terms of advantage from a socioeconomic standpoint may have a higher risk for adverse outcomes after a heart attack. As well, there's policy implications because at least in the United States, the Center for Medicaid and Medicare have decided that they will reimburse or penalize hospitals based on their level of readmissions or complications after heart attacks. But they haven't taken into consideration patients' socioeconomic status from where they present from. So we wanted to undertake this study in a large representative cohort across the United States and then stratify patients by where their neighborhood residential area is by socioeconomic status and wonder whether both clinical outcomes are affected by socioeconomic status and as well as quality of care associated with being from a higher or lower socioeconomic status to directly answer or at least give insight to that question. So this is a national representative sample of hospitals across the United States. There were over almost 400,000 patients in this sample. And these are patients that present with heart attack, so either chest pain presenting to an emergency room or being transferred from one hospital to another already admitted with a diagnosis of a heart attack. And those patients then were categorized based on using their census data from where they live, where they reside. And census data, then we know from census data that they can tell us about a neighborhood's household income, your residential status in terms of how many people graduated high school or college, what you do for a living, how many people are in a management or professional role. And so we can't say that on the individual level, but at the neighborhood level. So we categorize patients into the lowest SES group, a low SES group, a middle SES group, high or the highest, which are representative of the quintiles across the United States. And then looked at in terms of those reference groups, in terms of outcomes, we took the highest group, so those who are the most well off, as the reference group to see whether or not outcomes are affected in quality of care based on how you present from which neighborhood you're presenting from. So it looks like overall, both just when you walk in the door or after you adjust for differences between clinical characteristics, hospital characteristics, your insurance status, that there's a trend that those patients who come from the lowest socioeconomic groups tended to get actually better quality of care compared to those who came from the highest socioeconomic groups. It looks like those patients who present to hospitals from the lowest socioeconomic neighborhoods tend to present to regions that are more teaching hospitals, have better abilities to perform advanced surgeries, and so maybe there is a quality association based on where you come from that these patients are actually presenting to good hospitals and good doctors. We found that very interesting. On the flip side, we validated what's been seen in the past in that those are still the highest risk patients. So when you show up from a residential area that is of the lowest socioeconomic status, you still are at an increased risk for a poor outcome, particularly dying in hospital after a heart attack compared to their wealthier neighborhood colleagues. However, these effects were modest, and it looks like at least in the 21st century we're starting to see more equity in terms of care and hopefully for outcomes. And this may impact the policy decisions that are being put in place in terms of reimbursement based on the quality of care and risk of complications in those patients. So in terms of the clinical message, those patients do, I think, need a little bit more attention. Either they came from a more disadvantaged neighborhood or they're at higher risk. Nevertheless, they seem to continue to be a risk group that seems to do poorly compared to their colleagues, and so focusing on the quality of care in those patients seem important. I think all of us are making strides to do that and look for more equitable care. From a policy point of view, it does ask the question, and this is a little bit higher than my pay grade, but from a CEO level and from a Centers for Medicare and Medicaid level, whether we should be considering a patient's socioeconomic status and adjusting for that before we penalize or reward a hospital based on the quality of the care, because they seem to be intertwined.